drugs were stocked out at any one time. So on top of that, about a third of the drugs in typical African clinics are actually substandard or counterfeit. So that means that if you see a doctor, or, if you're lucky enough to see a doctor, or if your child comes in with pneumonia and is seen by a physician or a nurse, and they prescribe an antibiotic, there's a 50-50 chance that that child will not receive an effective antibiotic, which has, of course, catastrophic impact. So that would be a good example of saying, well, here's actually a problem. And then people looked at it and said, well, how do we solve that? And I think it was fairly clear early on from the work that we've been doing, as among others, that lack of information was, in fact, a fundamental piece of that. But the people who've actually done most, maybe, to actually confirm that is a thing called SMS for Life, which is just a very simple mobile phone application initially used for malaria drugs in, I think, Tanzania or Uganda. And they basically had the problem of wanting to, so they basically had the problem that, how do they ensure that there are antimalarials available at all times in all the clinics they're monitoring? So they set up the mobile phones with the pharmacist or someone running with the pharmacy, and every week they would send them a text and say, tell us how much you've got in each of these 3 different kinds of antimalarial. And then if they didn't get a response, they sent another one. If they didn't get a response, they called them. If they didn't get a response, they sent the guy out of the truck. And people very quickly realized they had to respond. And so what they learned from that was not only where the problems were, but that nearly always within the district there were enough drugs. And so they've actually been able to drill down from stock-out rates of in excess of 25% to under 1% in a relatively short time period. And so, I think it was interesting because it's one of the best examples of a pure information deficit. That it wasn't that they didn't have trucks, it wasn't that they didn't have drugs, and it wasn't that they didn't have staff. It was actually that they didn't have the information about what was going on, and it was all in the wrong place. And so I think it's a good example of really trying to say, well, is the system that I'm working on addressing a very clear identified need? We all know that other good things can happen, and if you have a good information system, there may be other benefits, or you may be able to add additional functionality. But if you go in at the beginning with at least one, or preferably 2 or 3 clearly identified gaps, and seek to address those and drill down on those, with a laser-like focus, then you're much more likely to get that buy-in and also be able to, get a sense as to whether the system is functioning correctly. Because then you can start to measure that. Because otherwise, the research question, what am I actually trying to evaluate, is fuzzy, and maybe you're building on these systems that's in a parallel universe to the real world. It looks really great, but actually doesn't quite solve the problem. And that, I think, is a very important trap that people fall into. And I think if you've got a good survey or a good analysis, or some health service research person who's actually helping you to identify what those gaps are, you're much more likely to then be able to frame the problem and then develop the system and address it more effectively. And of course, once you've done that, no doubt there'll be iterative cycles improving this, at least to a drive in the right direction. So that's really the first key thing. And then I'll go through these quickly, but I think we can then sort of come back and talk about things that people are particularly interested in. So specifications and quality assurance, from the software point of view, of course, everybody here probably understands that pretty well, but it's surprising how often it gets missed. So although it's not perhaps the primary focus of this session, it is a critical concern here that people are not necessarily defining specifications, they're not mapping them to a well-identified need, as we discussed, and then there isn't enough quality assurance. And that's the first stage, because that then kind of moves into the next stage, which is what is called system optimization. And there's lots of ways you could call it. It could be formative evaluation. It's really about, is the system performing to the level that we expected, or to a minimum level that is enough to do the job. And of course, that's something which has to be defined. But a simple example would be that I'm rolling out OpenRest to dozens of sites in Rwanda or Kenya or somewhere, and there are problems with power, and there are problems with networking, there are staff shortages, there are staff changeover, there are issues in terms of the software potentially. And so what you find if you look at it is that potentially many of the sites are not up all the time. Maybe some sites are down all the time for days or even weeks on end. Now clearly that is going to have a huge impact on whether anyone uses it at all. And I think there are sort of these levels of confidence that if somebody knows the system is usable, perhaps all but 2 hours a week. I mean, that's an arbitrary figure, but imagine a clinician, if this, it's down for half an hour or so during a busy clinic, you can get annoyed, but you can kind of cope. If it's down for 4 hours in a busy clinic, well then it's really a problem. If it's regularly down for long periods of time, you're simply going to pay. You just cannot rely on the system. And so that becomes a real problem. So I think the optimization side of things is incredibly important. It's maybe not as glamorous as doing the big randomized controlled trial and publishing the Lancet, but in terms of the actual impact and in terms of translating our work in something like OpenMRS into the real world of beneficially impacting on patient care, then this is obviously a critical piece. And it has some nice features to it, one of which is that this is more likely to make you friends with this. If you are doing optimization system and you're working with the development team and the implementers, you're identifying problems, and internally you're working with them saying, well, look, you still have problems with this, let's think about a better power supply, or people are having a lot of problem using this, we need to fix that bug. And then the user confidence goes up, and then everybody likes the system more. Well, actually you make friends. If you go straight in because you've been funded to do this proper formal summative evaluation, and you start evaluating all these sites and you discover there are all sorts of problems, it turns out that no one really did this kind of job properly. Everyone's embarrassed, people lose their jobs, they're out of shape, and ultimately you probably don't learn that much because you aren't in the space that is helping you to determine what is the true clinical impact. Because the true clinical impact of the system that's turned off is probably not that great. And it seems these all seem like kind of obvious things, but they happen all the time. And so what I'm doing is, in a study that we've proposed to in Rwanda, is actually to make this a requirement that the sites have to be optimized to a certain level. We need to define what those thresholds will be for uptime, for number of forms entered per day relative to the patient load, the number of times the system is used. So it could, for example, be used for patient lookups. It could be used to run reports for the Ministry of Health or just local clinical requirements. And then regular running of reports for data completeness and data quality. And then if you do those things on a weekly, or daily or weekly basis, depending on the measures, what you will do is then report those to some kind of dashboard. So then you know that the basic things are working. And then on top of that, the next step is to say, well, let's do a specific sample of data quality against reference data. So if it's a situation where you're entering data from paper forms, which is a common one with OpenMRS, then in principle it's relatively easy to do a randomized sample of forms, compare those to the EMR system, and then actually come up with a measure. And there's a measure called lot quality assurance sampling, which we started to use at PIH. And you can take a fairly small sample of like maybe 10 charts, and it will give you a sort of a basically red light, green light indicator, where we set a level of 70% as the quality level for just a very simple sample. And then you run this up very regularly, and you keep looking at those numbers and you see how well you did against your criteria. If it's direct entry into the system without there being a paper intermediary, well then you have to look at other ways of qualifying that. So it might be that you look at areas where you have some backup data, like you look at the quality of lab data, or you go back and you check, maybe with a sample of patients to see if their address is correct. And then once you've got that side of things going, then in terms of the clinical programmatic impact, there's a whole range of issues around there, and so I won't try and cover anything like all of that, but just the key question is who is actually interested in results. So what we say is who is the client, or who's the owner of this, the user of this. So there's a thing called utilization-focused evaluation, or user-focused evaluation, which is a little different from some of the traditional academic approaches. And what it says is the people who use the system, the people who are impacted by it, are the ones whose questions are most important. And if you then, working on this idea, you've done your requirements analysis, you really draw down and say, well, look at the clinicians, what is it that they're most concerned about? Say, for example, they really want access to lab data. Delays in getting lab data, slow down the clinic, they make it harder to treat the patients may not come back, so a positive TB result or a low CD4 count may not be followed up easily. So they say that that's something we want to work on. then you frame a study around those questions. Is the data timely enough? Is the quality good enough? Is the system reliable that you can always get it each day when you're at the clinic? And so then a study based around that is likely to then have strong buy-in from clinicians or from the other staff, and the results which you come out will be of great relevance. And so if the results are good, we'll say that's great, we trust our system, let's put in place a long-term monitoring process. Or if the results aren't good enough, then you can sit down together and say, well, what's wrong with this, how do we fix that? So that approach, it's different from the, like I said, the academic approaches, like the distant evaluator who's trying to measure this in a very formal way. And that doesn't mean there isn't a role for that, but it kind of ties in also to this idea of action research, which Tashi was commenting about. And there are many, I guess in some ways there are different sides of the same idea, or different terms for the notion that you're developing and implementing things, but you're also measuring what you're doing, optimizing it, but also reporting those findings. And clearly the hard thing here is when you start looking at actual clinical impacts and outcomes. And very often we look at this sort of from the different stages. So you may look at the data collection, the quality of the data, is the data accessible to the clinician, say, what are the outputs from the systems? That could be a report, or it could be a patient summary. What are the outcomes? Does that change the way that they do something? For example, maybe they get the TB result quicker, they get patients on treatment quicker. So that's a good thing, because then there's an earlier start date of treatment. So we see that as basically a measure of clinical impact. But it doesn't actually tell you whether the patient got better or not in a more formal way. So ultimately what you really want to see is that the mortality or the long-term morbidity of the patient, let's say, that disability, for example, is reduced. Now clearly to go along that progression from just data entry, data quality, through production of reports, to the point where you're actually measuring mortality, the scale and the cost and the complexity goes up. But one lesson again is don't start at the end and work at the beginning. You want to do this in order. You want to make sure this thing's running well. You want to start to see that you're actually having an impact on the way people manage those patients. It could be like reducing drug errors. It could be, responding to a lab result. It could be finding patients who are lost to follow-up who need treatment. Those are really good things to measure, and you know that they have slightly different impact. And then you can use those as the basis for the longer-term studies potentially. But that's clearly a bigger problem. Programmatic impact, that could be a lot of other things, about the way you manage clinics. It could be things like the drug supply. It could be, being more effective finding patients within the community who have a disease like HIV or malaria and getting them into the clinic or into the treatment program. And then finally, and these are not exclusive, there are other things you can measure. Economic evaluation is also important. And again, very, very little done up to this point. There are barely any economic studies of ecosystems and resource environments. And in some ways, it's a little bit more low-hanging fruit. If we all started to report the results for how much it cost to implement our systems and what was the running cost over the next 3 years, then that information would become really useful, and we can very quickly get a sense as to what things actually cost. And there's also some interesting results that we're seeing from studies, and actually from Baobab in Malawi. They've been looking at some of the questions of reducing the number, the costs of care potentially with information systems. And one example that they looked at was the number of failed lab results. And they said, well, actually, they found in the lab that I think it was more than 10% of the samples, the labeling was really bad and they just thrown away. And then there was a small percentage where the sample was duplicate because the result hadn't got back to the right person or the patient moved or something. And so they found that the lab was actually a big cost center for that hospital, but something like 15 or 20% of the lab costs were wasted. And then they said, well, we actually have a system for barcoding, providing barcoded ID for the patients, and also printing barcoded labels we stick on the samples for that. And you can show very clearly that reduces the number of misidentified samples and the number of samples that are unprocessable very, very dramatically. And so although typically we think of this as a cost center, developing e-health systems, there's some tantalizing evidence that if you use it correctly in very specific ways, you may in fact save money, which would be a shock to everyone, but it's kind of nice to know that potential exists. And of course, as we move over the last few years from really expensive heavy-duty desktop machines with a lot of power requirements, down to very lightweight netbooks with very long battery life, small power requirements and so on. The overall hardware and logistic costs of setting these systems up has gone down pretty dramatically. So the marginal cost of setting up a system and extending it is actually much lower now. So that's also cool. So what I thought was, I think those are all the main things I wanted to kind of talk about more formally. A couple of other things that would be interesting. How do you compare studies from different sites? And I think one of the gaps that we've seen over the years is that when there are evaluations, as I said, there aren't that many of them, but those that have been done, they're typically all over the place. They're good, well-designed ones, but mostly there are not so well-designed ones, and then there are ones at very small scale, and they're all different. And so it becomes quite difficult to then combine that information and understand better the big picture. And Saptarshi made some really good points earlier when we were talking about the question of how do you generalize, and even if you have a randomized controlled trial, which as I said, it's pretty rare in this field so far, trying to understand what that actually means in the real world is difficult because these tend to be very specific. They're measuring a very specific set of variables, and the other factors that determine whether something a system is successful or not in the staffing, the infrastructure, the experience the staff have had in previous systems, and a whole range of different variables, clearly can have a big impact on whether something is actually generalizable from one side to another. So I think that's the key thing. So one of the things we're trying to do with the Mobile Health Alliance, the Health Alliance, and some other organizations is develop examples of studies, look at the different stages at which you might be evaluating who are the key users. So it could be the clinician, it could be the administrator, it could be the patient, it could be a government official who's kind of applying for this, and then also looking at what are some standardized study designs that could be applied more widely, so everyone actually says, well, we need to measure these key variables and we'll report them in a certain way, and then actually you can look at the studies from Kenya and Tanzania and Rwanda and have a reasonable sense as to how those studies compare. And that would be a huge win. And I think that's really a big goal, that we can actually see people, for example, in the FNS community, being able to adopt relatively simple study designs and apply those as part of their projects and report those numbers and say, well, this is data quality relative to some simple metrics. I've talked enough. What are the kind of questions that this brings up, or what are the questions that you're particularly interested in answering?
I was thinking that this is a kind of what is called medical technology assessment instead of, it is something which, whenever you evaluate cost and benefits of some medical procedure, where the impact of technology is a big one, you have to follow the number of different parameters that you said, and surely it would be very useful to have a list. I mean, and to understand which one is going to have the bigger input in the situation you are evaluating. One of the I was just thinking the time parameter. This is probably in some places, the time you spend to go and have the service you need is not that important, because you are there is many times maybe you are so compelled to do something, you don't have any alternative. But I'm interested, as I was telling you, on what is the concept of underserved populations, because it is more general use. And in what I know, in wealthy countries, the value of time is a big one. And so the assessment of the cost can be the one. I mean, if I'm able to evaluate what is the time spared, because the service is so it's a better one. I mean, it's working in a more efficient way. People are able to spare their own time. It's difficult to measure the value of single hour for every single person. But I suppose that it's an important parameter that could be, I mean, could be considered. I have another example, just a bit of time. In an experience I've been told of in Angola, there is an Italian organization who is providing some kind of visits, going in the villages with a mobile clinic. So in that case, they said that they had so much more interesting outcomes as far as the number of people visited and at so treatment provided increased a lot, just because they were able to announce the fact that that day the mobile clinic would have been there. Then people collected, because there was a sort of reference person in the village, and when the clinic arrived, they were able to optimize the time of the people, of the resources they had to put there. So time is an important parameter. That's what I feel.
No, I think it's a great point. Anyone else?
Hamish? Actually, in the National Telehealth Center where I work, we also have experience in terms of the evaluation of health information systems. Although an interesting thing that we've noticed is that there are a lot of evaluation tools made available already in the internet, and then there are already previous studies that make frameworks on technology evaluations. But somehow, when you want to evaluate specifically the application of health information technology, for example, and then put it side by side with the clinical impact and the programmatic impacts, it's not that many resources available that we can follow as a framework. So we've had experience with the PRISM, the Performance of Routine Information System Monitoring by USA. And then there's also...
GSI, right? Yeah. JS, Johnson International.
Oh, yeah.
Yeah, but it is funded by USA.
Mm-hmm. And then also the Technology Acceptance Model. I think interestingly, maybe we can also learn if there is a way wherein we can adapt these existing frameworks and then model it so that we can evaluate the information system related to health, or I mean health information systems in general. So Hamish, would you have any ideas in terms of how we can modify these existing things?
Frameworks. It's a really good point, and I think coming back to this question about how do you standardize evaluation, how do you come up with data that is more comparable to insights. There are a number of frameworks that people have been working on, and so one I sort of actually was going a little bit through the PRISM idea before, because they have a sort of 5-stage process looking at the data collection and the data completeness and data quality, and then this issue of outputs, outcomes, and impact. It's kind of a logic frame, I think is the other way some people describe that. And so they look at these different stages and say, well, are you meeting the goals across those stages, and then how does that data then get used more effectively? And the key thing with PRISM, I think, is that it's intended to be about routine data collection. So the distinction is that in the past, people have tended to either do a clinical trial where it was a very formal study designed for one very specific purpose, so which was usually very focused, or maybe it was like a survey that would be done by WHO, or maybe they would ask hospitals to fill out some kind of a form and then it would send it into some central site would be entered. But it was really kind of a separate thing you did. You had to report to the government, and it was just annoying, and you wasted a whole bunch of time on Friday afternoon when you wanted to go home because you had to do these forms. Routine data collection is when you're more, obviously what we're really the business of with OpenMRS is actually making the routine collection of data part of the normal practice, and then using that data for all of these different kind of uses for reporting as well as for clinical care and for disease surveillance and so on. So that's kind of PRISM is about looking at how do we actually optimize that data, and then KDS is a new framework developed by some colleagues, and they actually tried to look at a broader range of different ways of evaluating stuff. The Longman Claim is another fairly famous framework looking at just more general IT evaluation, looking at IT systems are functioning well, more along the performance and system optimization approach. And I think one of the questions at the moment is, can we kind of boil these things down into some more simple rules and then actually organize that into maybe a set of tools on the web? And so the Mobile Health Alliance has this website called The Hub, and then actually we're going to work to put together some frameworks that let people go in and say, well, I'm interested in this kind of study, and this is the kind of groups I'm interested in answering questions for, and then actually these are the tools that are available. So, and you used, is it PRISM and KDS you've been using for?
Actually, we haven't used the KDS yet, but we applied PRISM in the study of an electronic TB registry. And I'm not sure if we did it correctly, but what we did was we looked at it in terms of the technological, the behavioral, and the structural evaluation methods, and we assessed it because sometimes the evaluation is mainly catered towards the technology, whether the technology is being accepted by the end users or by the patients. But in terms of PRISM, what we appreciated then was that even though the technology is okay, the TB registry wasn't really being used that much, that often. And we found out it's because of the behavioral, how it wasn't really introduced in a way that the health workers can integrate it with their normal routine inside the health clinics. And partly also because of the structural, because sometimes in the change of government, there isn't any follow-through of the previous mandate in terms of using information systems like that. And that's why we liked PRISM before when we used it in ETR.
No, I think that's a great point, and very much, that it's important to emphasize that the technology is only part of this problem, and clearly the behavioral and the human side of things is critical. I think that comes back to the point that if the system's not being used, that's a major failure of our system optimization point. That should show you that site's actually below 70% utilization or whatever your threshold is. I mean, that obviously means that you're not really getting benefit from it. And I think your point earlier about time, that actually is critical in countries that have limited resources and very limited numbers of medical and nursing staff. Then it's an incredibly valuable resource. So if you bring a system that slows them down, you're really messing up the whole health system. So in a way, it's actually more important than a rich country. I mean, we talk about the sort of cost effectiveness in a country like Italy or the US or whatever. But actually, if you're in a clinic, you have 50 patients to see, and you have only one doctor, you really can't afford to mess with that. So that's for us a big, big concern. Can we actually even, for example, take the system we have in Haiti and have the physicians enter the diagnoses when they see the patient? Is the time it takes to scan a barcoded ID, bring up that patient, go through a couple of screens that with a limited coding list, put that in, is that actually going to slow them down sufficiently that they won't do it all at the problem? So I mean, I think it's a very important issue. And so that's a factor which could really make a difference in success or failure.
I have a question. Do all clinical e-health systems need to really solve the problem of, the impact, should the impact always be considered in terms of health outcomes? And that to me is a question that I've thought about, and understood. Not, I mean, finally the goal would be that maybe, but may not in cases where you want to say increase organizational efficiency for the health system, where you're taking time to do something and then it reduces time. So you're seeing more patients, but you're not necessarily able to change the health outcomes that are happening, because that may not necessarily be only by the time that you're providing the kind of care that you're providing to the patient. So I'm not sure if impact can only be measured using clinical outcomes. So I wanted to understand.
I mean, I think it's an interesting question, and I guess there isn't a very clear answer to that. In general, I think that yes, you do want to look at clinical outcomes, because that is the goal of the overall health system, to improve patient care and improve quality of life and so on. Sometimes you're a little bit of a distance away from that in, say, you're changing something like the workflow of the clinic, you may improve the workflow. But that actually could be pretty beneficial, and as we said about saving time for very valuable provider time, that could free up providers to see more patients or to spend more time with the patients, and maybe spend more time chasing up lab results. So I think it's a generally good thing, making the system more efficient. If you have limited resources to your health system, you're able to see more patients and manage patients more cheaply, then actually you do impact on care. I think we've seen that with the displacement, from doctors and nurses and other kind of more senior credentialed staff to community healthcare workers and district health officers with more limited training. The way you do that task shifting and maintain quality, then not only you save money in the short term, but actually what you do is you expand the access to care effect, because then you can afford to spread that out, and that then becomes a major health outcome, or it's likely to.
But yeah, there's also, it may not really affect the health system at all, but increase the provider's happiness maybe could be one impacted thing. So how do you measure those things? In the sense, most evaluations would tell you, or a global picture of the thing would tell you, or a global measure or an indicator would tell you that the infant mortality should decrease from whatever levels to whatever, according to the FDG.
Exactly.
But I'm saying maybe the clinician feeling that they're more happier, maybe more efficient, could be a better indicator in some sense.
The providers are happier.
Yeah. Or the patients are happier. That kind of.
Well, I think that those are good outcomes. I think despite the complexity of doing more definitive studies, it's still important that they fit into the overall picture. Because ultimately, once you've got systems that work well, you're using them, you still need to ask the question: should this be used more widely in the country, or should we spend that money on something else? Should we buy more radiology machines instead of buying this sort of new normal places? And what are the relative benefits of that? And I think we would like to emphasize what we do, but we have to be kind of fairly open, perhaps a little ruthless with ourselves in terms of, are we really making a difference? And if so, let's do the things that are most impactful.
So I was going to ask you, I think point you mentioned earlier on about kind of like the bias of an evaluation. So you could do an evaluation sort of like an audit where you're looking out for mistakes or how people didn't do the implementation very well. But sort of like thinking forward, and when you're at the planning design stage, what are some of the things they need to put in place, like prerequisites for to enable useful evaluation as you move forward?
So, you're asking what type of things need to be put in place?
Yeah, so like, what are good prerequisites for useful evaluation?
Good sites. What would be the characteristics of a site that was good?
No. So you're planning for an evaluation study, for example.
Yes.
Let's say, for instance, like we're going to be implementing autonomous large scale. So, and there are things that we want to find out. So, problem is clearly identified. We know what we're trying to achieve. Very clear goal and everything. But for the evaluation to be useful and to provide useful information, there are things you need to put in place. So, from your experience, what are some of those things that you think about earlier on?
Oh, so that you can actually plan an evaluation that's going to really give you data that's valuable to the country, to the users, etc. Well, one of the fundamental questions is can you actually come up with comparison sites, control sites in this situation? And that's been one of our questions for rollout. And do you have a situation where certain sites have the system early and other sites have it later? In which case you can compare early, the sites that have the system early and the sites that have it later. So you can look at that. And now, of course, one of the questions is how do you select sites? Because if the early sites are all the ones that have better staffing, better power, well then they're probably going to do better anyway. They have more shorter distance from the major city. So you do need to have some way of defining what of sites you think are reasonably equivalent, and then randomizing within that block. So that can be a big concern, because if you don't really have an effective control, there are things you can do to optimize it and to measure that how well you're reaching certain goals, like the sort of data quality goal, but you can't really say this has made an impact in some way, or this has changed in some beneficial or non-beneficial way the quality of care. So that's one thing. I think that clearly defining upfront what are the most valuable things that are likely to come from the system. So hopefully you've seen in a small number of initial sites that there is evidence that the system is improving access to lab data, or is improving the quality of recording of previous diagnoses, so that when patients come back, what the problem was before. So that defining that would be good. And then I think also, if you have a system already in a lot of sites, you may be in a situation where you can install a new module which is supporting a particular area, say maternal health, randomize which sites get that early or late, and then look and see whether that improves some aspects of the maternal health project. And there's one thing which we haven't really talked about, but although we think we'll talk mainly about the information system having a direct impact on some aspects of care or the system, it may just be that it's measuring something important that you couldn't measure before, and you didn't know that actually quality of care was poorer, or you were missing certain people, or certain patients were not receiving optimal treatment. And simply by improving your reporting and your measurement, you may then drive quality improvement, which may or may not be another information system. It may be that you just recognize that your loss to follow-up rate is high, and you use community healthcare workers. But we've seen that when we start to measure stuff, there's a danger in that, of course. So what do you think is the problem with the fact that when you put in the information system, you often identify quality of care problems?
So that's the question.
What do you think is the problem or the danger that you put in an information system, you collect information on, say, primary care patients coming to a clinic, and you identify problems with the quality of care?
Well, just get to learn that the problem exists.
Sometimes you find they shoot the messenger.
Right.
So you have to frame the stuff a little bit carefully. Sometimes you come back and say, hey, guess what, guys, you missed the diagnosis on 30% of patients.
Right.
Like, click, go away. On the other hand, if you say, well, what are the problems that you're facing? And they say, well, it's really annoying every time these patients come back. I never know what the previous treatment was.
Right.
Well, then you go and say, actually, look, we're not capturing all that. Different conversation. So that's been one of our recent conversations, trying to make this a positive thing and something where people are really engaged and involved in that. You've been looking at some of this, Dawn. You've been looking at some of these questions a little bit, I think, in your...
Oh, no, I've been looking this up, actually.
What's that?
I've been looking at some of these frameworks.
Have you any thoughts about it?
No, I guess, part of the reason why I'm doing this conversation is because with the RAVE project, we had a workshop a couple of weeks ago, and we've been talking about how to proceed with evaluation, both in the short and the long term.
Sure. They're important questions. Also just in terms of looking at some of the challenges in starting rollouts to multiple sites in Rwanda, and any thoughts about how evaluation might be used in a helpful way or an unhelpful way?
You mean specific for that project, or?
Well, yeah, just giving you insights into it. if you had any comments, just because I know that you've been looking at some of these questions in terms of how implementations are working, but doesn't matter.
Yeah, I mean, to be honest, I'm still on a bit of a learning curve with this. This is the first implementation I've gotten.
Okay.
But there's another form of evaluation that we haven't talked about, I think, is for implementations that are starting up. They need to evaluate what systems should they implement actually. So there's also an evaluation of the current state of affairs. So what modules would you like to put in, and do they meet the, so there's the framework which Richard Heeks put forth, which says design actuality gap, and if the gap is broader, the implementation is going to fail, and tolerate says that you can use it in a
design
actuality gap.
yeah, that's right.
So that's how you can actually, I mean, in a prescriptive way, say that we need to reduce this gap, and there are a few steps in what kind of gaps would exist. And so I think that's also an important phase where while you're designing the artifact or going to implement the artifact, that you can evaluate the existing state of affairs and see the design that you're putting in, would that meet the requirement in the end. And so the evaluation feeds into the design again, and then that is again evaluated and again. So it's a cyclic process of design and implementation.
I think as many of you know, the guilty secret is that even in the richest countries, EOR systems and information systems are not always as good as they're cracked up to be. And the debate rages in the US about what works and what doesn't, and what are the pros and cons of different systems, and whether commercial or open source or academic systems are better. And some of the the advantages of different approaches. So I mean, I think these are still often hard questions to answer. Is a system really addressing the needs, and what are the costs? Leaving aside the often huge economic costs actually putting these things in. I mean, I think the big health system in Boston, Partners Healthcare, which is I guess I work for one part of, they're actually going to scrap all of their famous academic information systems in the world. The real pioneering systems in the world, like Dragon Street system, and the cost of bringing this system called Epic. The initial estimate is $600 million, but it's going to be more than that. It's probably probably around $1 billion. And it's a very rich organization, but it's a huge amount of money. And so you don't, if you mess that up, you're going to have enormous impact on your organization and mission here. And that's happened many times. Most famously, in recent terms, in the UK, in England, the National Health Service, which sadly was entirely predictable to most of us within about 4 hours of starting that project, which is depressing, true. Because they made so many mistakes. But part of that was because they had not identified clearly that the systems they were looking at would address the problems people have. And then when that design actuality gap started to rear its head very clearly, instead of saying, okay, let's take a step back, let's reassess what we're really trying to do here and what the real goals are, they actually mandated that they shouldn't talk to doctors and nurses and stuff like that. So the gap never got closed. And that wasn't the only problem, it was a key example. Any other questions? So thinking about your studies here in the Philippines, you're planning one for CHITS as well?
Yes.
Would you mind telling us a little bit about
So actually, not only for CHITS, we also have a national telehealth service program. So it's a partnership. It's actually a project of the Department of Health in partnership with the National Telehealth Center. And what we do is we provide telemedicine services, and we kind of also provide a mobile data reporting system. And those systems are like deployed right now in 2 regions in the Philippines. So for CHITS, and for the National Teleservice Program, the NTSP as we call it, we also included an evaluation aspect, or it's like an evaluation process wherein after a few months of implementing the system, we would see the usability and the usefulness of the applications for the health center staff members, and also see if we are at par with what the Department of Health needs, since it's basically the information that we gather eventually goes to the Department of Health for executive decision making. We would like to see if we are doing it right, if we are making it more efficient for them to acquire the information, if the data reporting system can somehow increase or decrease the time needed for the Secretary of Health to see what really is happening in these regions in terms of health indicators like maternal care. What I appreciate in this lesson was looking at the evaluation stages, because sometimes you have so many ideas on how to evaluate, but you don't know, well, I myself don't know what would be the optimal steps to do it. How do you group the evaluation? Like sometimes we get to mix or to integrate it, the clinical impact and the system optimization as one, and probably in this case we can further identify what indicators would you want to see in terms of system optimization, and what indicators you would like to find out in terms of clinical impact. So now we haven't really identified these indicators yet. They're still in the process, but at least we know that we can still use the PRISM for it. That's happy for me. And also the Richard Hicks design actuality gap. We can also apply it as well.
That's really helpful, thanks.
Mhm.
I mean, I think one comment, I didn't want to overcomplicate this, but we've actually been looking at kind of frameworks where you have actually not just two, you mentioned, in fact, more than that, but essentially you can look at the different stages. So think about going from the, actually that would be the requirement stage to the, say, this specification phase, and then the system optimization phase, and then in the impact phase, so say the clinical impact, you could actually divide that into lots of different levels. And then down here you might have some kind of a long-term evaluation. So that could be a slightly different approach. So you might be saying, well, we're interested in the optimization piece, and then we're already at that point. We may then say, well, you're actually looking at a smallish number of sites, and you're working, to get them up to a certain level. And you say, well, now I think we know how to do this right. You know, we understand enough how to get the thing running smoothly. We've got good feedback from users. We are reasonably confident that other sites will be able to use it. But then they probably won't be perfect, because there may be some difference in the sites. So you still have that question of some more optimization. And people discuss, you know, if you're doing evaluation and you have a formative evaluation, so you've done this optimization piece, and then you go on to do a final evaluation where you're trying to look at real impact, that those sites are privileged over sites that don't have a formative evaluation. Because that formative evaluation or optimization piece really benefits the implementation. And it's one of the reasons why it's so expensive to take, say, a EMR system in the US. Often the license costs. So the classic example is the Children's Hospital in Boston, another teaching hospital, very, very famous and sort of pretty rich hospital. But they decided to go for a Cerner, which is a private EMR system. And they paid about $3 million for the software license. And by the time they had it running, they trained everybody, they made all the improvements and changes to the software. They didn't have any change from $100 million. So the actual software cost alone was a tiny fraction, it's like a 30th of the overall cost of the project. And that was, part of that was this optimization piece, and part was the very high cost of the one-time piece. Okay? And so then there's also the question, once you've got things running, you may put a lot of effort into really optimizing things, to training everybody, to making sure the equipment is running well and so on, and then you leave and go do something else. So the question is, does it still run in 6 months or a year or 4 years' time? And so that is a very critical question, obviously, for a health system and for clinicians. And unfortunately, very frequently, stuff breaks down unless there's an ongoing interest and monitoring. That's why I think, again, what I'm interested in is not just the optimization piece, but this dashboard, this notion that we're actually recording on a daily basis everywhere for good what's happening. So you can say at any stage, well, we're out, 3 sites are down this week or today, and then we should do something about that. So that then you have a reasonable chance to ensure that there's a long-term stable system. And that will also teach you things about, what kinds of hardware seems to be most reliable and so on. So that long-term aspect is really important. And so a system that is still used and still liked and is having an beneficial impact 4 years down the line is a very different matter from something that looked good for the first 6 months and then basically failed. And unfortunately, a lot of systems are in the second group. Okay, well, sounds like we're kind of, actually one other thing I was going to say about this, you can also take this from the point of view of different users. So, you have one user group, and then maybe this might be clinicians, and then you might have managers, and then this might be patients. And so you can actually look for which stages we're at, what type of information we want to collect, what kind of users are we looking at. And then within that group, there are different study designs. There may be examples of studies that have been effective for looking at clinical impact from a patient's point of view, maybe using text messaging or something, or looking at sort of long-term impact from the point of view of a clinician. Okay, cool. Any last questions? Observations?
Yeah, about users, and I was thinking about who are the people who are involved in. So we are talking about processes, but processes are managed by people, and there are also, of course, levels of responsibility in every single process. At which level should an evaluation look at and be, able to provide also advices to the your aides what is going to be done?
I mean, who should be the client, if you like?
Yeah, in a way. Because if I look at an organization, I know that there are people and processes, and we have been talking about mostly about processes. Now, right at the end, you said, but of course you have a number of users, and among the users you have different level of responsibility.
Right.
So, how would you look at a system in a way that you don't need to have an evaluation for each person, but at the same time have a good probability to understand what is going on and where is the problem?
That's a small question. I think it's a challenging one to answer because in some situations a particular user group may have a very different experience. And one of the interesting studies where people have taken systems from one site to another, and the role or the sort of level of seniority of people using it is different. And so sometimes, in an education system in a company, it's used maybe for a restaurant chain or a factory or whatever. It may not be that nice to use, but the people who use it essentially are paid to use it.
Yeah, on the other side, every time you introduce a big novelty in an organization, it would be better to consider a sort of change management. So in this case, let's say that you have an organization which is using a paper report, and you want to introduce an open MRS to.
Right.
Of course, I'm talking very broadly because every situation is a different one. But so would you start with introducing the fact that something is changing, or would you provide the solution and say, well, we are starting to use this, and maybe the best would be going to paralleling the usage of paper and the informatics, and then trying to transform all the procedure in electronic form.
Again,
And
these
who are the people involved? I mean, because, for instance, in the situation I know in a hospital, doctors are prescribing and nurses are providing the medication. So there are two completely different processes, because doctors could be the one who are able. I mean, at the end they say, okay, that's not difficult. I'm just going to a list, and instead of writing, I just put a check on something, the medication in the prescription and so on. Then, when the medication is going to be provided to the patient, and the control of the time, of the dose, of everything has to be done, you have a different person, so a different professional kind of, I don't have the word, but I mean, you have a different role.
Yeah.
You have a different role, and among these roles, there are some coding.
Sorry, you need to get going for the group picture.
Oh, group
Because they're
picture.
starting it a little bit earlier.
No, I mean, I was thinking.